Okay, so the question is, a 38-year-old male is brought to the emergency room with a history of a road traffic accident. He looks pale, pulse is 120 by per minute, blood pressure is 90 by 60 millimeter of mercury, respiratory rate is 20 breaths per minute. Examination reveals multiple rib fractures, right side reduced breath sound and dull percussion. Note what will be most likely diagnosis. Now let's suppose we are drawing here the lungs. This is right side and this is left side. In right side there is dull percussion node with a reduced air entry. What will be the diagnosis? So if the patient has a road traffic accident and rib fracture is there, now, after fracture of rib, we can conclude that artery has been ruptured and hemothorax can develop, because during hemothorax, dull percussion node and reduced air entry occurs. And stony dull percussion is for pleural effusion. So what will be the answer? Filial chest? No, filial chest cannot be there. Hemothorax is there because of road traffic accident. Open pneumothorax is not there, and tension pneumothorax cannot be there. So the answer will be hemothorax, means accumulation of blood in pleural cavity, which results into decreased expansion of lungs. Another question is, a 45-year-old gentleman has anemia. Blood CP shows hemoglobin is 7, MCV is 115 femtoliter, TLC is 2.9 into 10 power 9, platelets is 85, and reticulocyte 1%. What will be most likely diagnosis? Most likely diagnosis will be can be concluded from MCV. Aplastic anemia cannot be there. This erythropoietic anemia is not there, and hemolytic anemia will not be there. Megaloblastic anemia will be there, because in megaloblastic anemia MCV will be changed. MCV is mean corpuscular volume. It is normally 80 to 100. If it is less than 80, then that is microcytic anemia. If it is greater than 100, that is megaloblastic anemia. So the patient has 115 femtoliter MCV. So MCV is 115. That indicates that patient has megaloblastic anemia, means RBC has been increased in size. So this is megaloblastic anemia. Another question is, a 30-year-old woman, gravida 2, para 1, present at 28 week of gestation with amenorrhea, labor pain. On examination, she is found active labor, history of vaginal discharge, foul smelling, milky white in color. Now, what will be the cause of preterm labor in this patient? Preterm labor cause will be bacterial vaginosis, because there is foul smell discharge out of vagina. So foul smell discharge of vagina will indicate the bacterial vaginosis, and that will lead to preterm labor. Now, if we look at the causes of preterm labor, then polyhydramnios can be cause of preterm labor. So polyhydramnios can be there is the in preterm labor, but if foul smell is there, then bacterial vaginosis is there. Now the another question is, a primary gravida with prolonged labor, lithotomy position, is unable to walk after delivery. Her son, she could not dorsiflex her right foot. Nerve mostly involved. Now peroneal nerve supply the foot. What nerve is damaged? Dorsiflexion of right foot. That will be common peroneal nerve. Compressed sacral nerve. Deep peroneal nerve supplies the dorsum of foot. So anterior aspect of leg. So the patient cannot dorsiflex the foot. So that's why deep peroneal nerve damage is there.